Thank you, Rob. One of the things that I find really interesting is that as this whole debate has changed over the last 20 years, how much the focus really is on delivery system reforms and overall ways of looking, not just getting coverage, but finding ways of redefining how providers work to provide, as you said, focus on quality and not volume. So we're getting reactions now from 3 stakeholders in government in New York, 2 from the legislature and 1 from the executive. And we're honored today to have the chairs of both health committees, Senator Kemp, the chair of the Senate Health Committee, and Senator Richard Gottfried, the chair of the Assembly Health Committee. And what's really remarkable about their history is, despite differences in political party, they can look back together at a remarkable number of signature pieces of legislation. During their joint tenure, New York enacted several laws that expanded access in very meaningful ways to uninsured New Yorkers. Major enhancements in Child Health Plus, the establishment of both Family Health Plus and Healthy New York, a hospital charity care bill. So they're huge expansions of coverage. They reshaped the Medicaid program with the implementation of Medicaid managed care, and the same year provided strong managed care protections for all consumers. There's a lot more that the 2 of them got done, and we're going to start by hearing from Senator Hannon.
Thank you. That's the most intelligent introduction, because we have overlapped in all of these statutes we've had a chance to pass. And of course, now we're into the era where we have to perform all the things we've passed. I'm going to just give you a couple of talking points that are thoughts that are running through my head, because I'm in the very process of trying to work on a draft of an exchange bill to submit. We've gone through a couple of roundtables. We have the ability of everybody to give us expertise. Robin from Vermont, I've heard before, she talks faster than I can listen. I have nowhere near the mastery of all of this, but I have just a couple of thoughts. And just a couple, because I'm sure that the executive in the body of Judy Arnold will have the answers. The first is we have a particular challenge. You all know the statistics. We've got 1 in 4 New Yorkers on Medicaid. We have a fairly low thought as to how many people will get coverage when we do have Obamacare come in. Maybe about a million people, which as a percentage is about 5%. But the challenge is that we've already have Child Health Plus, we have Family Health Plus, we have a pretty robust amount of public coverage. And yet now people are starting to think, well, we'll just expand that. And it's not the case. We're trying to do an insurance model, and at the same time we have a Medicaid model. And it's the insurance model that we can't screw up. We have a very robust small business insurance coverage in this state, and actually independent municipal insurance. For some other endeavors that we're doing in terms of mandate relief, I was looking at how municipalities insure themselves. I thought everybody was under a state plan. There's a lot that are not. Benefit trusts and how to do that right, and et cetera. So as we go through this insurance, we ought to make sure that we don't have people dropping coverage who now have it, especially as in the nascent stages of any type of exchange. I also feel that because of that type of coverage, we should be very strenuous at the beginning of using the option under the federal plan of the SHOP, the small business insurance offering, and as separate from the individual coverage. I know this. I know that for some people it's very important that the people who are still left as individual coverage somehow have access to insurance. I was one of the first proponents of community rating, but I know that we also have to take a look at what are the incentives that are built in, because we gained a lot in a certain era. It was the 90s. It was a lot of adverse selection. We gained a lot for community rating. Now it has some other options. We have to let people make some choices on their own. I think we should take advantage. It's the governor. We should take advantage of the options that the federal law allows and see what we can do, including when it comes to the catastrophic, see what we can do in regard to health savings accounts. They get into ideological points of view. I don't have the ideology. I mean, I've helped do the Family Health Plus and the Child Health Plus, but I do think economic incentives do work, and especially as we're trying to get young people to have coverage and figure out how to do it, we should explore that vigorously. The last but most important thing, and it's really a question that I have that overrides it, is what's the cost? When we're doing a government program, you're always looking at the cost, but you're really also looking at the revenue streams. And I don't think either are clear here, at least not to us yet. And that's going to be very important in setting parameters, setting benefits, and then answering what's going to be a very delicate question for us. What do we do in New York to go beyond the basic benefit package when and if the federal government ever comes up to that? We have at my last count 57 statutory requirements to be included in health insurance in this state. Some are costly, some are not so costly. All are wise. They didn't get there because it was a whim. They all had a group of people who said we should add this. But the question will be, when you get to the exchange, you try to have competitive packages, how are you going to pay for those? Who's going to pay for those? Whether they should be included, whether they can be options. Thank you.
Thank you, Senator. Just a quick note before I bring Senator Gottfried to the podium. We've gone back a long time in terms of talking about public insurance in New York. In 1992, the Assembly passed the only fully financed single-payer bill that's ever passed the legislature. The fully financed is the tricky thing. The Assembly could have been accused at that point of raising $28 billion in new taxes. So that was a pretty bold thing to do, and I got to work with Dick on that a bunch. So, Dick, thank you. Richard.
Well, good morning, everyone. It was just about 20 years ago, it was in the spring of 1991, that Richard Kirsch and a handful of other people, probably some of whom are in the room or colleagues of theirs were in that room, met with me and explained the logic of single-payer health coverage, and I was convinced and have been an evangelical fundamentalist, what have you, advocate of the single-payer concept ever since. Just to let you know where I'm coming from. New York, it's often interesting to me to listen to discussions of both before, during, and after the enactment of some of the federal healthcare reform, and to hear people from other states describing their systems. The most dysfunctional state government in the country, according to some people, enacted large chunks of all of this so long ago that nobody seems to remember or give us credit. The market reforms that were so much of the hallmark of the federal healthcare reform we enacted in the early and mid-'90s. The notion that, as we were hearing the outlines of the Commonwealth Care Plan, coverage that is largely funded by the taxpayers. Actually, I think we probably fund it maybe at a higher percentage than Massachusetts, although I guess that depends on the income level. But with the benefits designed by the state, the premium, to the extent there's a sliding scale, set by the state. You pay the premium to the state, not to the plan. Eligibility is done by the state. The coverage is delivered through plans that contract with the state. That is pretty much a description of Family Health Plus and Child Health Plus. We enacted Child Health Plus in, I think, 1991. We have expanded it since. We enacted Family Health Plus in '98. So nobody gives us credit. That's okay. As I say, it's amazing how much you can accomplish if you don't care who gets the credit, and I often have to remind myself. Mild digression. The opening lines of Confucius are, "Isn't it a pleasure to learn and to put into practice what you have learned? Isn't that a pleasure to have friends come from afar? Isn't that a joy?" And here you all are. And if your work is not recognized, but you don't care, isn't that a mark of an exemplary person? I keep reminding myself. At the end of March, New York enacted, as part of the budget, 2 extraordinary pieces of legislation as part of the budget. Well, more than 2, but 2 that I have in mind. One is we enacted state authority for accountable care organizations, and covering all payers, including Medicaid. Hardly anybody seems to know that we did that. We also authorized an expansion of our Sparks hospital data collection system to cover all payers in all care settings, and to authorize the state to make some really extraordinary use of that data in connecting in with electronic health records, etc. I'm going to use my last minute to pose a question, because apparently we're all supposed to pose a question to somebody from one of the other states. So, I have a question for Vermont. I think there is widespread belief that care should be delivered in some form of care management format. In New York, over 4 million people on Medicaid get their care through Medicaid managed care. We enacted as part of the budget the expansion of that concept to just about everybody who's on Medicaid to get their care through some sort of care management. Many of us contemplate that instead of managed care companies doing care management, at some point that should evolve into integrated delivery systems doing that care management in a payment reform environment, and some people call that an accountable care organization. I'm assuming that in Vermont the Medicaid program is a managed care program? No?
So our Medicaid program in Vermont is a little funky.
Well, all right, let me just...
Yeah.
So my question is, what do you contemplate at this point, or is that one of the things you're working out, where care management will be performed in a managed care carrier that would be an intermediary somehow, like we use in Commonwealth Care, or some other mechanism? And can you tell us about that? Thank you.
So I'll go ahead. I'll just talk from here unless that's disconcerting for people, because I feel a little low. So our Medicaid program in Vermont is actually the entire program is what we call a public managed care entity, which means we've gotten flexibility under a Medicaid waiver to do the types of reinvestments that managed care Medicaid programs do into population health and Medicaid beneficiary health that are normally not Medicaid eligible for funding. But we don't contract out with a private entity in a private managed care concept for Medicaid, which is what most states do. What we're contemplating doing around care management is not having an intermediary, but expanding on our Blueprint for Health program. Our Blueprint for Health program is creating community care teams that work with doctors' offices to integrate service delivery at a local level and management for care in the physicians and the nurses' hands. So we're moving towards trying to integrate service delivery over time, starting with this kind of advanced practice medical home model combined with a community care team. And the community care team works with a number of different practices to coordinate a particular patient's care. So that's our concept. We probably, our Green Mountain Care Board, when they get up and running, will start to look at the concept of accountable care organizations, whether that's a model that might work in Vermont. One of our challenges being a rural state is that our service delivery is very dispersed. We do have Fletcher Allen Medical Center, which is our academic medical center. We have about a third of our population goes to New Hampshire, to Dartmouth, Hitchcock. And then we have small community hospitals in every region with affiliated practices. But it's not like an urban area where you have a much more integrated kind of up and down service delivery model. That answers your question.
Thank you, Robin. So our third representative of New York State government has been charged with implementing the brilliant legislation that Senator Hannon and Assemblyman Gottfried passed over these years. Judy Arnold has spent more than a decade and a half at the Health Department really implementing programs like Child Health Plus and Medicaid Family Health Plus, and now looking at the exchange. And her current title is Director of the Division of Coverage and Enrollment within the Office of Health Insurance Programs in the Department of Health. Whoa, Judy Arnold.
Thank you. It's always interesting to hear from other states, especially neighbors, and how they're wrestling with the issues that we're currently wrestling with. And I'll echo what Assemblyman Gottfried said, in that New York has been ahead. We've implemented many of the aspects of the Affordable Care Act that other states are struggling with. I mean, we have many of the private insurance market reforms already implemented or needing tweaks as opposed to major changes. And we have generous public health insurance programs that we're really at the federal minimum requirement or maximum requirement, depending on your perspective, for Medicaid, with the exception of childless adults. That's really the only newly eligible group that we'll be adding. But with that said, we still have 1 million people who are eligible today for our public coverage programs who aren't enrolled. And we expect, so we'd like to do simplification and other things to bring those populations in. And we've been working on that for years. And we anticipate that the exchange will bring in another 1 million people through private insurance options that are above the Medicaid levels, small employees, and another population. So it's really a substantial increase in coverage. And I agree with Senator Hannon, we need a marketplace that works and is effective to be attractive, cost-effective, and provide high value. And with that, we're currently engaged in discussions on the establishment of the exchange. I don't have any news for you today. Stay tuned. We've identified several principles that are guiding our work. And those of you who have seen the public forums we've been running around the state doing already know these. But we're saying the exchange must promote affordable, comprehensive health insurance. We're looking at affordability being promoted by a large pool, more healthy lives coming in, trying to get those young, healthy people who've abandoned the individual market and back into individual health coverage, and the availability of federal subsidies on a sliding scale to make it more affordable. The exchange must be consumer-centric. We really see this being a real game changer for the way the public programs are accessed, but also small business. That a consumer-centric process which allows easier to apply, recertify, manage changes, where the consumer is really the focus, not an eligibility worker or perhaps a small employer. The consumer really can make these decisions. And we want the exchange to meet the needs of small business. The insurance should be more affordable with minimal administrative burden. When you talk to small businesses, those are the two things they say over and over again. The exchange must be transparent and accountable. And finally, maybe most importantly, it must work. It needs to be up by 2014. It needs to be nimble. It needs to have flexibility because we don't have a lot of time to do a lot of things. So we need to have something that works by 2014. We're also looking at one technology platform to support eligibility determinations and changes in eligibility, so people can go across a whole continuum of coverage, from public coverage and as income rises to subsidized coverage all the way up to full price coverage. And these changes, so today we've lived in this world with two systems for CHIP and Medicaid, where people have gaps in coverage as they move between the programs. And we know 50% of the people move between Medicaid and CHIP. So there have been studies that say that's going to be about how it's going to be in the exchange as well. That number didn't surprise me because I see it all the time. And we also see a world where we still continue to have helping hands. We have people who help people navigate this complexity, maybe even more importantly for the people who are new to health insurance. Not so much the people who've lived in public coverage, but maybe above those levels. And finally, we're right in the throes of trying to answer decisions about active versus active purchaser, the basic health plan, all the things we've heard about today that the states are working on in legislation. We're looking at those. We've hired the Urban Institute to help us with some modeling things like how many people can we expect in the exchange. The numbers I gave you are our own estimates, but we'll get those modified and updated. What does the basic health plan mean for our risk pools? That's an important question to us. We have Wakely working with us on some exchange design option choices that we can then bring forward to people. And then the social interest solution is helping us on technology. So that's just an example of some of the people we've reached out to for consulting assistance, and I'm sure there'll be more. And I will close with a couple questions from Massachusetts, actually. One is on employers. I mean, one of the things that comes up in many of our public forums and many of the meetings we have is how do you make the exchange attractive to small business? And Massachusetts, there's all these small businesses won't come in or they'll leave, and the small business employees will wind up in the individual market, and that's not been the experience in Massachusetts. So I'd like to know what was key to that, and then sort of a corollary question is, as you think about the basic health plan, how do you wrestle the question of, to the extent you go the basic health plan route, do you dilute what's left in the exchange? And the key for the exchange is a big risk pool. So we're wrestling with, do you carve that population out and do you leave enough risk there? So those are two. I have more, but those are two.
But those are really terrific questions. So on the small business area, that's been one of the hardest nuts to crack by far. So the number of small businesses, and I thought this would be very attractive to small businesses. Basically, they would kind of cede the responsibility for picking the plan and let their employees go to the exchange, and then you have an online system, you pick the best plan for you. I particularly thought at the time it would be really good where the managers and the well-paid people would want a higher price plan, but the low-income workers would want maybe a cheaper plan with a more restricted network, and the exchange would facilitate that. It hasn't happened. And what we're finding is that employers really want control over the benefits they're giving to their workers and don't want to give that up. As much as they complain about the hassle of health insurance, they're just not ready to give that up. So that has not gone as well as I think we had hoped. But one thing it has not done is sort of dilute the risk pool. So we have the prices for coverage for individuals and for small groups are the same inside the exchange and outside the exchange. They have to rate them as one big entity no matter where. So whether the employer is buying insurance through the exchange or going to a broker and buying it directly from an insurer, the prices are the same. So there's no price advantage there. The one difference I guess that the state is trying to do is to save a little bit on the broker commissions. And frankly, that's been a political issue, and I'm sure it's going to be an issue in New York, an issue in every state. Because brokers are like travel agents in a way. Technology is replacing some but not all of their functions. And the way they bill right now is they get a percent of the premium. And in the future, I think what they're going to do for companies who want a broker, and there's a lot of good reasons why you may want a broker, they do more than health, they do lots of your insurance, is you pay on top and the company pays rather than the insurer paying the commission. And but they see that model as really threatening, and so they've been very resistant. So that's been part of the issue.
Thank you.